We'll just give another 2 minutes for people to join. Okay, I think we've probably reached a steady state. So good morning, everybody, and you're very welcome to the Ireland East Hospital Group UCD NDTP Grand Rounds, something we do on the last Friday of every month. And this one is slightly different, so promises to be very interesting. We're going to talk about we're going to hear presentations from the AHSS grant awardees. And just to talk a little bit about it, the UCD Health Affairs AHSS grant aims to enhance the collaboration between IEHG, its affiliated community health organizations, and UCD, College of Health and Agricultural Sciences. So we aim to raise the awareness of UCD Health Affairs and to foster synergies between UCD CHAS, UCD Health Affairs, IEHG, and its affiliated community areas. And there's an annual call for applications in January of each year. This year we received 28 applications, and the AHSS grant was awarded to 4 projects, 25,000 each. So we'll have the 4 successful projects for this year, and we'll have 1 from last year. And the grant is really to support health and science related research, educational innovation projects that clearly will enhance the concept of an AHSS, and they will align with key college and school research and our education strategy objectives. So unfortunately, Tim Lynch, the Chief Academic Officer, can't be with us this morning, but we're going to watch a little video which he had previously made with Health Affairs on academic health science system.
Worldwide research and innovation are improving healthcare at an extraordinary pace. However, rapid access to medical knowledge, personalized precision medicine, advancements in technology, and an aging population are all significant challenges. Delivery of these specialized treatments and innovations through the traditional hospital model can be costly, and the health system can become overwhelmed. To help address these issues, 7 hospital groups were set up in Ireland. A hospital group links a number of hospitals to a core university and their associated community healthcare organisations, providing better integrated care. To ensure the continual development of sustainable, quality and safe healthcare and success of the hospital groups, we propose to establish an academic health science system, an AHSS. An AHSS is a fully coordinated partnership between a university and a healthcare system designed to deliver quality care hand in hand with teaching, training, research and innovation. Most importantly, the change from the traditional hospital model to an integrated academic health science system will improve patient care in local communities. Ireland has some of the best doctors, nurses and allied healthcare professionals in the world, but we lose many to immigration because of limited career opportunities. Embedding teaching, training, research and innovation into clinical services will improve staff job satisfaction, resulting in better recruitment and retention of high-quality Irish and international staff. Furthermore, clinical academic directorates within the AHSS will pool resources in key specialty areas such as cancer, cardiology, mind and brain disorders, informatics, women's and child's health, and genomics. Improvements in research and innovation will result in new treatments and new technology, leading to world-class outcomes for our patients. Other benefits of the integrated AHSS include increased research grant funding and the creation of an environment to encourage commercial opportunities and entrepreneurship. This will result in added value to the state by contributing to the knowledge economy, by improving state finances, and by improving population health and well-being. The AHSS offers a real prospect of achieving greater levels of productivity and efficiency, sustainable improvements in patient care, better patient safety and outcomes, as well as world-class research and innovation in healthcare. To find out more, please visit the UCD Health Affairs website and the Awardees Hospital Group website.
Thank you very much. And clearly, academic health science system is the way forward in combining clinical care research, innovation. So it's something that needs to be worked on for the future. So we'll get on to the presentations now, and I'm delighted to introduce Dr. Denise O'Brien, who's joining us from Spain, a successful applicant from last year. So Denise joined UCD in 2006 as an assistant professor, lecturer, and associated dean for undergraduate studies in the School of Nursing, Midwifery and Health Systems. She has taught in the discipline of midwifery since 2000 and has extensive experience in curriculum development and design at both undergraduate and postgraduate level, and is the program director for the MSc in Advanced Practice Midwifery. Since joining UCD, Denise has continued to expand her research portfolio with her colleagues in UCD, the National Maternity Hospital, the Ireland Hospital Group, and with international collaborators. The central focus of her research profile is improving maternity care and women's experiences of childbirth. And Denise is going to talk about the Labour Hopscotch framework, promoting active physiological childbirth. So I'll hand you over to Denise. Thank you.
Good morning. Thank you so much for that lovely introduction, Thomas, and thank you to the IEHG and the AHSS for the invitation. I'm absolutely delighted and very happy to give up time on leave to present this, because we were so grateful to receive the funding for this research. And you could, can everybody hear me okay? Just a mindful.
Yes.
Perfect. So you could see in my first slide, and time is of essence. We're all extremely busy and I have 10 minutes. So first slide is UCD Academic Health Affairs, which is so important. And I agree completely what you've said about this is the way forward for research, this is the way forward for funding, and this is the way forward for improving services. And for me personally, it's going to relate to maternity services. And the other aspect of the slide there, you can see, is the Joint Research Network. And that's key to this project, and it's key to why this project got funded. And we were delighted. And I'm only one person of that team working in UCD, but one of my other hats is I'm a member of the Joint Research Network, which was a research network set up, and I'll discuss that further. So we'll keep going. So this is last year. We were so delighted. There's a team of us, and you can see here I'm the UCD PI. I'm from the School of Nursing, Midwifery and Health Systems. My background is I'm a nurse and midwife. I left clinical practice in 2006. I started clinical practice in 1987. And then I moved to UCD and have loved UCD since. And one key thing was the alignment between UCD School of Nursing and Midwifery and Health Systems, and at the time it was the National Charity Hospital, and has since expanded to the IEHG. So the members there are the innovator and creator of the Labour Hopscotch, Sinead Thompson, who's here, who formerly of the National Charity Hospital, but is on secondment at the moment to the National Women's Health Infant Programme. My esteemed colleague, Associate Professor Barbara Coughlin, who unfortunately couldn't make it today because she's presenting findings from another research project in the UK, and Professor Fionnuala McCall from the School of Medicine, Lucille Sheehy from the National Charity Hospital, Mary Brosnan, Jean Docherty, all key players in this funding application. Paula Power was on the original application but has moved role. She's no longer the Director of Midwifery in St. Luke's. She worked for the IEHG, but Margaret Ann Hogan, I think, might be on the call and is joining the project. And again, you can see from Wexford, everybody remembers what happened with Wexford, and all these have implications. So Helen McLaughlin, Orla Mongan from Wexford General Hospital in terms of maternity services, Mary Corbett and Caroline Early from Mulligan. So there are sites. So what did we get funding for? So the purpose of our study that was funded was to further and evaluate and examine how to digitalize the Labour Hopscotch framework. The Labour Hopscotch framework was a piece of research that we did, and that was what I'm going to refer to as Labour Hopscotch 1. And this funding that we were awarded was to enhance further that original innovation and research to enhance its accessibility, feasibility and acceptability within the Ireland East Hospital Group. It had already been established in the National Maternity Hospital. So in this funding application, the sites involved, our partners were the National Maternity Hospital, Regional Hospital Mulligan, Wexford General Hospital and St. Luke's Kilkenny. So our AHSS funding is a fully coordinated partnership between the School of Nursing, Midwifery and Health Systems, the School of Medicine and the 4 maternity hospitals. Key to this is that joint research network, which was well established. The joint research network was established in 2007, and the founders were the Director of Midwifery and Nursing, Mary Brosnan from the National Maternity Hospital, and the then Dean and Head of School, Professor Michelle Butler. This current study was designed to evaluate and implement quality care through midwifery-led innovation and research. And the aims and objectives are aligned and embedded with midwifery knowledge, philosophy, and their scope of practice. The overall objective of our AHSS-funded study is to generate knowledge and evidence translation for midwifery teaching, clinical competence training, and research impact and innovation. And this is to improve maternity care experiences and facilitate birth strategies. So, what is the Labour Hopscotch? The Labour Hopscotch is a midwifery innovation created by Sinead Thompson in 2015 in the NMH at the time, the National Maternity Hospital. And this was in response to concerns raised by senior midwifery leadership. And that was the Director of Midwifery, Mary Brosnan, at the time, who called a focus group or workshop with her clinicians and partners, raising concerns about the high epidural insection rates in Ireland. And why was that? Because the evidence shows that physiological birth, powered by the innate ability of the body, benefit mothers and babies, but also can reduce potential risks posed when using medical interventions like epidurals and cesarean sections. So despite the evidence that physiological birth is good, the rates of physiological births continue to decline in Ireland. Now, excuse this because I had to do this in my holidays in Spain. This isn't my usual standard for slide, but what you have in front of you there is the OECD cesarean section rates. And if you look there, I've highlighted Ireland. That's a rising trend. We are unfortunately one country whose cesarean section rates are on that upward track. So the Labour Hopscotch, the story from Doodle, and this is really key to the funding. November 2014, there's the doodle, you can see it, that Sinead did in response to, I suppose, a request from the Director of Midwifery, how can we solve this problem? So Sinead started to doodle. And from that doodle in 2014, if you now do a Google search, what is Labour Hopscotch? I did that search, that screenshot on the 28th. It comes up straight away if you put in Labour Hopscotch. So just a little bit of the background, and Sinead will answer all this. Sinead Thompson created this, as I said, in response, and this is what it is. It is, I'm going to let you read what she said. We interviewed her as part of the evaluation of the project, what she thought it was. And what Sinead wanted to do was really, for women to be involved and their partners in training for labour. Women need to take responsibility for optimal fetal positioning. What is that? About the physiology of labour, the head on the cervix, and these are the strategies that Sinead was suggesting should be implemented. Mobilisation, lunging, birthing ball, mat, all responses to the physiology of labour and an active birth. So this is Sinead in action. This is what it looks like. A community midwife, and this is what Sinead and those involved in midwifery care are best placed to state it, because a community midwife providing domino home births, Sinead has expertise and in-depth knowledge of the physiology of labour and birth, many years supporting women during childbirth. So we started Sinead, I met Sinead in 2015. Now, to be honest, we trained together in General in Donegal many years ago, and we both worked in the National Maternity Hospital. I left in 2006. We worked in a very busy unit there together from 2001. Sinead is a community midwife and now works with the AHSS in the National Women's Health Infant Group, developing antenatal standards. But back in 2017, in 2015, when she brought this idea to me, and I said, oh my God, that's amazing. That is amazing. You need to do research. And And that's where the collaboration started. And we brought it to the Joint Research Network and established group and said, this is a fantastic idea. This needs to be, you need stats, Sinead. It's wonderful. I love the idea, but we need the numbers. You need to prove it. And we had fantastic support from the National Maternity Hospital. We had fantastic support from the HSE, because through the Joint Research Network, our usual processes, we applied for funding to the NMPDU, the Nursing Midwifery Development Unit. We applied for funding for 17,500 and we received it. Also, as part of the journey, we brought it into UCD. This was under the good guidance of Associate Professor Barbara Coughlin. We attended the UCD Agile Work Smart Together group and presented the study as one of 3 as part of the work of the Joint Research Network. And interestingly, even though at that stage we were only getting started, we were recommended to apply when we were completed to the UCD Research Impact Award. And we did, and we were one of the runner-up winners last year. It was fantastic. So that's just to give you a little bit. So this study cost the initial study cost 17,500. So what were the findings? So data collection started 2020 and our report was 2019. Total of 809 women. This was conducted in the National Maternity Hospital, just to state. 38.5% reported having epidural analgesia while using this labour hopscotch framework, lower than the hospital epidural of 52. 77 had a physiological birth. Only 9% had a cesarean section birth, which was lower than the hospital rate at that time of 29%. And that's why this study got momentum. So other more important findings really were that in addition, all the key stakeholders have reported that implementing the labour hopscotch has resulted in positive change. What positive change is that? Women are more initiative taking during childbirth using steps, these steps that you can see, this is from Waterford Hospital, using the steps of the labour hopscotch with coaching from their birth partner or midwives, enhancing confidence and nurturing that relationship. And by relationship, I mean with their birthing partner. Incidentally, this is another study we just published. It's a separate study, but I just thought it was key here that the epidural rates, we were looking at birth satisfaction. I know it's very small, and I'm sorry now because I'm working from Spain. The epidural rate remains lower, and that was 2019, just a snapshot, key. So in 2020, Sinead and I were asked to present the findings from our published report to the Department of Health, and we did, and look at the time in February 2020. On foot at the presentation to the board of NWHIP, a decision was made to roll this out nationally. I was down in Waterford on the 30th of May in relation to advanced practice, and this was a picture that I took. Also, in 2020, they made a decision to add it to the National Antenatal Standards in Education. Here, I'm sorry about the speed, which is we have a lot to cover in 10 minutes. Here is Sinead kindly shared this with me. This was the state of play before we started this labour hopscotch 2. As you can see in green, this is where labour hopscotch was fully implemented. Orange is where training was requested. You can see Wexford is part of that, and then interest expressed. And I'm delighted to confirm to you that all those oranges are now green. So it has been implemented nationally because, as you can understand, the pandemic had an impact. Okay, this is our publications. The labour hopscotch has translated midwifery knowledge and evidence from practice, from the National Maternity Hospital, started in the National Maternity Hospital, to UCD, from the UCD to the Awardees Hospital Group, to global. What do I mean by global? I'm not just talking about the publications. Sinead has presented the labour hopscotch in France recently. There is interest in France in implementing this study, replicating our study. And we are under discussion at the moment with a university in Germany. They actually are going to replicate it. So the funding that we've received, what is the vision? What do we want to do? The vision for the current project, which we're briefly calling Labour Hopscotch 2, is this funding has afforded the team an opportunity to expand further on our initial project and implement digital technologies into our original research design and propose final output, thereby responding to the societal changes such as the need for valid and evidence-based information for women and their birth partners. Key to this is the recognition of the readily available, rapid access to information via social media. It is key that women and their birth partners get evidence-based information, such as the labour hopscotch. So this is the plan. This is what we're using our funding for, and this is what we are doing. We are developing a pro forma type digital app of the labour hopscotch so that women will have it at the touch of their hand. Our first study, we didn't have the digital technology. Where are we now? So just to say what we've done in the last year. I got ethical approval from the National Maternity Hospital, from the South East Research Group, which incorporates Kilkenny and Wexford. In terms of Mulligan, the ethics has yet to be completed for that. We have responded to queries. There were multiple queries, and understandably so, with multi-site. So we are now I have responded to that, we're waiting, but we made a decision to go ahead with the study. We needed to do a scoping review. A scoping review, there is very little information around the use of digital apps for midwifery-led innovations around physiological birth. We set up co-evidence, and this is wonderful. Anne has joined the call. Anne is a third-year midwifery student in a degree programme and is a summer scholar. And myself and Anne have set up our scoping review and started that as progress around that. So that's coming along, as they say, nicely.
Sorry to interrupt, Denise. Just we have 4 more presentations.
How long am I going, sir?
It's 8:23, I think.
2 minutes, okay. So we are at the stage that the survey is ongoing. We've set up the Qualtrics platform. We have piloted that survey, the original survey that we used, which was paper and pen, but this is digital, and we're at the data collection stage, and the next stage is our focus group with service users in the National Maternity Hospital. I'm really sorry, I usually keep to time, but once I start talking about the labour hopscotch, that's me. So I'm going to stop and just say thank you very much to the team involved. Thank you.
Thanks very much, Denise. Sorry to interrupt you. And yours is the project from last year, so we're delighted to have the feedback from it, because the other speakers are grant awardees from this year, so they haven't had the chance to complete their studies as yet. So I think the stats there are fantastic in terms of the reduction in epidurals, an increase in physiological birth. So great work done, and thank you so much for taking time out of your holidays.
No problem. Thank you.
Really appreciate that. So we'll just leave questions to the end, because we're a bit tight for time. We have 4 more presentations to get through. So I'm just going to go ahead and introduce Dr. Neil Docherty, Associate Professor of Anatomy at the UCD School of Medicine and Principal Investigator at the UCD Diabetes Complications Research Centre at the UCD Conway Institute. And Neil has a long-standing research interest in the physiology and pathophysiology of the kidney and GI tract, and his current focus centres on the role of obesity and diabetes as modifiable risk factors for the development and progression of chronic kidney disease. So I'll hand you over to Neil, who's going to talk about renal reserve assessment in obesity, renal functional reserve assessment. Thank you. You're muted, Neil, at the moment.
Off to a bad start, so you can hear me now?
Yes.
Yeah. Thanks so much, Thomas, for your introduction, and good morning, everyone. So yeah, we were very pleased to receive this funding to be able to initiate some more translational research connections between the Diabetes Complications Research Centre on campus and the UCD Clinical Research Centre at St Vincent's, with a view then, as we incrementally progress through this project, to bring in some partners from across the IEHG network. So the purpose of the study that we've been supported to conduct is to look at how we can develop and sort of pilot the deployment of a protocol which would allow us to actually assess what we would refer to as subclinical renal impairment and obesity. That is evidence of kidney injury which is early enough to not be detected or be classifiable as chronic kidney disease according to standard classification systems and clinical biochemistry. So joining me on this project, I have clinical colleagues from UCD and essentially St Vincent's, so Carol LaRue, John Holian, Pat Murray, and Liam Martin, so expertise across endocrinology, metabolic medicine, nephrology, and then Pat Murray as a nephrologist intensivist and also the current head of the director of the CRC. So we're well set up to carry out this study. So why would we want to look at renal functional reserve in obesity? Well, I'll just draw your attention in this slide to the this study from 2017, which highlights the fact, it's probably under-recognised fact that chronic kidney disease is an important substantial component of obesity-related morbidity and mortality. So the Global Burden of Disease obesity collaborators in 2015 were able to quantify this and actually showed that here in purple, if you can see, this constitutes the contribution of chronic kidney disease to the morbidity and mortality associated with obesity. So it's second only really to the cardiovascular disease component. So it's a very important contributor to morbidity and mortality in obesity. So the data behind this, I'm just trying to move on a slide. Okay, I think my computer's a little bit slow here to move this slide, so I will just have to, for goodness sake. Bear with me for a second. Tomas, are you still seeing the daily slide? Yeah.
It's the daily slide with the graph.
Okay. Yeah. Okay. It's just this. It's just not moving. Oh, here we go. So it's moved forward now. Yeah.
Yeah.
So what is the evidence behind this association between obesity and chronic kidney disease? Well, actually, the sort of the logical or most parsimonious explanation would be to make a connection between obesity and then metabolic disease, particularly type 2 diabetes. And everyone knows that type 2 diabetes is a big risk factor, or chronic kidney disease is a big complication of diabetes. But in actual fact, independent of the presence of diabetes, obesity is a major risk factor for chronic kidney disease. And this study here from Garofalo from 2017 conducted a meta-analysis focusing in on the impact of obesity independent of diabetes on risk of chronic kidney disease. And they followed up over 600,000 cases over 5 years and showed that there was a 28% increase in what we could define as chronic kidney disease. That's an estimated glomerular filtration rate below 60 mils per minute. And actually, obesity is associated with an incident albuminuria rate an increase in incident albuminuria rate of 50%. So it's quite strong evidence that obesity is linked to chronic kidney disease. And you might think, well, that's only this data was derived independent of diabetes, but one would think, well, maybe it's only in people with some kind of metabolic complication. And to a certain extent, that is true. But we can see, if we look on the x-axis of this graph, which is looking at patients with a stable BMI over 3 years and looking at their kidney decline over 5 years, we can see that as we go up the categories of obesity, so obesity starting here at a BMI of 30, as we go to the higher levels of obesity, the difference between what we would refer to as metabolically healthy obesity in the hatched line here and metabolically unhealthy obesity here in the solid line, the hazard ratios start to narrow. So actually the increase in body mass index per se starts to cause a cumulative increase in renal risk. So early in the trajectory of chronic kidney disease, let's say it's both symptomatically and clinically silent, according to current biochemical detection methods. And these are essentially based on assessment of glomerular filtration rate using serum creatinine as a surrogate and calculating from serum creatinine the glomerular filtration rate according to, and estimating it according to an equation, and also then detecting or quantifying the amount of protein in the urine. So by definition, chronic kidney disease is an abnormality of kidney structure for function present for greater than 3 months. And we can then classify it according to gradation of decline in renal function assessed by estimated GFR, coupled to degree or absence, presence, and severity of protein in the urine. So really, to be considered as having any type of chronic kidney disease lesion, you have to fall into this highlighted category here. So you have to have a GFR below 60 mils per minute and have moderately or severely increased albuminuria. And obviously, as we go towards the bottom right of this classifier, the renal risk is increased. However, how do we detect patients who are already on the trajectory towards chronic kidney disease but are below the threshold of 60 mil per minute as the cutoff for chronic kidney disease, or who are early in the trajectory of albuminuria development? So these patients, can they be detected? And importantly, in the context of obesity, could we identify them early to indicate sort of prophylaxis or early intervention to prevent renal disease progression? Much of the work in this area, and we've been involved in some of it, relates to looking at prognostic biomarkers in blood and urine. But this current protocol or project that we've been funded for aims to actually use a more dynamic stress test of the kidney to look at sort of what would be to unmask early renal damage, or essentially detect renal deficiency before the GFR declines below 60. And the method that we want to use is quite interesting. It's to try to assess renal functional reserve. So this I would describe as a kind of a kidney stress test, analogous in some ways to a cardiac stress testing. So we're really challenging the kidney to see how much it can augment its filtration capacity. And so in patients who fall into this category here, where they would really be clinically silent, they may already have ongoing attrition of the number of functioning nephrons or filtration units in the kidney, which is a kind of a negative prognostic sign for further renal decline. So we would consider, in normal circumstances, if you have good renal function, then not all of your nephrons are functioning at 100% of their filtering capacity. There's a certain degree of reserve available. And so in someone with a full quota of renal function, if you increase blood flow to the kidney, you can then augment the filtration rate, and you can actually detect a difference between basal and challenged renal filtration. One way of doing this is to give people a protein load, an oral protein load, which once it's been digested and absorbed, the amino acids act to increase renal blood flow, and you can then detect an augmentation in renal filtration rate. And this increase in glomerular filtration rate is because each individual nephron starts to increase its individual nephron filtration rate. So we would call that individual nephron hyperfiltration. Then collectively, this causes an augmentation of the global glomerular filtration rate. So if we look at the bottom right here, the baseline glomerular or resting glomerular filtration rate might be around 100 mils per minute. But if we give an acute oral protein load of about 1 gram per kilogram, then we should be able to augment the GFR, glomerular filtration rate, to a stress GFR. And the difference between baseline and stress GFR is the renal reserve.
Sorry,
Yeah.
Neil, we just we have three more to we only have till 9 o'clock. So
okay, so I'll carry on. So really what we wanted to do is to be able to detect whether patients with obesity actually lack this renal reserve. In other words, even though they may be normal on GFR, that actually they are already using 100% of their capacity of nephrons. So this a lack of renal reserve is we consider a negative prognostic indicator. So we want to do this in 3 ways. First of all, we want to establish the technique in a healthy cohort. Then we want to do a pilot study in people with BMIs in the obese category. And then we want to do a longitudinal prognostic study. So this will follow the process of a feasibility study, then the pilot study, and then ultimately we'll carry out the longitudinal study. I won't go into the time-wise, I won't go into the methodology, but it's a 6-hour study visit, which we will implement at the Vincent CRC, but could be rolled out. We would hope to roll it out at other sites, other CRCs around the network. So I will leave it at that. I'd be interested if anyone has any questions about it. Sorry for taking longer than I should have.
Thank you very much, Neil. That's really interesting. Unfortunately, we set an impossible task. We asked you all to do a 10-minute presentation, so it's quite challenging to do that. Now we have 21 minutes left, and we have 3 presenters. So I know people have other commitments at 9 o'clock. So if we can try and maybe just give a summary and try and keep it to time, we may run over a little bit. So next up, we have Jonathan Drennan. And Jonathan is a professor of nursing at the UCD School of Nursing, Midwifery and Health Systems. He's undertaking primary research on nursing workforce in Ireland, which has developed and implemented systematic approaches that determine safe nursing staffing levels in medical surgeons, emergency and older person settings. And in addition, he's working on a Horizon 2020 funding project that is involved in an organizational redesign in 64 hospitals across Europe with the aim of improving the health and well-being of healthcare staff. So a lot to get through, I'm sure, Jonathan. So I'll hand over to you, and we'll try and make up some time if possible. Thank you.
Thanks, Thomas. Just make sure I'm not on mute. Can you hear me okay?
Yes.
Perfect. I'll try and get through this as quickly as possible. I'm conscious of time. So this study is looking at the health and well-being of the health workforce across maternity settings. We know very little about the health and well-being of maternity staff. We know a lot within the acute settings. Just to acknowledge the team from School of Nursing, Midwifery and Health Systems, team from the National Maternity Hospital, includes nurses, medicine, and our health and social care professional colleagues in relation to it. So what do we know? We know that prevalence of job-related burnout is much higher in the healthcare sector than any other sector. Education, finance, the commercial side, we have high levels of burnout within it. We don't have a lot of data on burnout in midwives and colleagues working in obstetrics and gynecology, and hardly anything around our health and social care professionals. We do know from recent data that around 1/3 of midwives experience emotional exhaustion in their work, and this has been exacerbated by COVID. Jean and Denise are with us today, have done a very good paper, and they've looked at the relationship in relation to that, and it leads to reduced empathy and reduced motivation. Around, again, about 1/3, just over 1/3 of doctors working on obstetrics and gynecology were identified meeting the threshold for burnout. This is usually the emotional exhaustion scale on the Maslach burnout inventory. What does this lead to? It leads to high rates of anxiety, depression, substance abuse, unfortunately higher rates of suicide within the professions as well. And then we know that there's poor patient outcomes, loss of productivity, illness, and so on. There's 2 ways to deal with this. One way is the secondary, what are called secondary interventions, individual stress intervention strategies, things such as mindfulness, management training, counseling, and so on. They're important, but from the research we've done, which I'll talk about in a moment, what nurses, doctors, and health and social care professionals really want is an organizational redesign at organizational level rather than individual level. And this is looking at things that impact on the work environment, things like heavy workload, long working hours, inadequate staffing, and so on. And this is what this study aims to do. It builds on a Horizon 2020 research study that we're doing at the moment called Magnet for Europe, which has involved 64 hospitals across Europe, where we're implementing Magnet principles within the acute hospital sector. And now we're looking at the transferability of these within the maternity setting. Those of you who've worked in the US may have come across Magnet hospitals. These are hospitals that are giving an official designation. They have hospitals that have high levels of staff retention, high levels of job satisfaction, and high levels of patient outcome, good positive patient outcomes when compared to comparable hospitals within it. We don't know a lot about doctors and health and social care professional perceptions of health and work environments, are not extensively studied, and particularly not in the maternity setting. So this is what this study is aiming to do. I won't go into the Magnet principles in detail, but basically what the organizational design involves is ensuring that there is transformational leadership within the organization. Staff are empowered to have a say within the running of the organization. So, for example, there would be NCHD councils, staff nurse councils, health and social care professional councils that have a direct line of reporting to the board, to senior management within the organization. Encouraging professional practice that's based on the introduction of new knowledge and using empirical quality results to improve practice within the setting. So this is probably will be more towards stage 2. How do we know that we need these more of an organizational design? Well, we surveyed over 6,000 nurses and over 2,000 physicians across 64 hospitals in Europe. And when we ask them what they want, the things that come up are, for nurses, it's to improve staffing levels, reduce documentation burden. Even a high proportion of physicians want to see improved nurse staffing levels. But when we look at physicians, what they want as well is improved physician staffing levels and a reduction in bureaucracy and red tape. Again, what we're seeing from staff is that they lean more towards organizational redesign. If we look at the least favored interventions, they are things like meditation, reflection. Nobody really wants resilience training anymore. I don't think people can get any more resilient after COVID-19. So what we're really looking at is the organizational interventions rather than those individual. I'm not saying those individual interventions are not important, but we're looking at those organizational. This is just some very quick data that we've collected across the 64 hospitals across Europe. If we look at nurses, those who work in a poor environment, 28% report emotional exhaustion and 38% intend to leave. If we look at those, compare those figures who work in a good environment, only 17% experience emotional exhaustion. It's still a high enough figure, but certainly not as high as 28% that we see in a poor environment, and 21% compared to 38% intend to leave. The work environment, we look at things like staffing adequacy, whether there's foundations to provide care, the strength of leadership, collegial relationships, and involvement in the running of the hospital. When we look at physicians, those physicians who work in poor hospital environments, 35% are meeting the threshold for burnout, and 47% intend to leave. Whereas we can compare those physicians who work in a good environment, which is classified by the practice environment scale, only 16% reach the threshold for burnout and 15% intend to leave. So we can see big differences there within the organizational environments that that are associated with burnout. So what are we going to do? We're working with the National Maternity Hospital, our colleagues there, to measure a number of baseline indicators that we know are associated with the organizational environment within people work. We're going to measure burnout, job satisfaction, health and well-being, intention to leave, absenteeism, presenteeism, levels of staff workload, organizational work index in the environment, and then the association between burnout, intention to leave, and work environment. So the basis for the study is the cause of burnout and other mental health issues is situated in the organization of the work, not in the individual. Individuals focus on symptom stress and how to cope with it, but that's not what health professionals want. We're going to look at an organizational intervention that removes the cause of the burden and creates healthy work environments. Organizational interventions are highly preferred by staff, and the improving your hospital environment as an effective approach to retain healthcare staff, which was mentioned in the opening video. And with this retention and recruitment, we see that there will be better patient outcomes. Thank you.
Thank you very much, Jonathan. I mean, this is obviously very close to my heart, and this is the single biggest problem we face certainly in emergency medicine at the moment, is staffing, and particularly nursing, well, medical and nursing staffing. So we can't keep our departments open if we don't have staff to work in them. So this is hugely important work, and hopefully your conclusions will you know, the attrition from, I think, all hospital, all parts of the hospital, particularly the emergency department, we're just hemorrhaging nurses, and you know,
yes.
So thank you very much.
Thanks, Thomas.
So I think we were due to have Aisling Mulligan, but I think she was unable. So I think we'll move on to Patrick Murtagh. So Patrick is a final year ophthalmology SPR, currently working in the Royal Victoria Eye and Ear Hospital. He has a special interest in ocular oncology, and he's due to start an ocular oncology fellowship in the Eye and Ear the week after next. And his project is entitled Quantifying Circulating Tumour DNA in Uveal Melanoma Patients, a pilot study. So thank you, Patrick.
Great. Thanks, Thomas. Many thanks for the kind introduction. I presume you can hear me and see?
Yes. Yeah.
Great. So I'm not going to keep it too long. I'm going to do a quick whistle-stop tour of our project. But again, many thanks to the Academic Health Science System for giving us the grant to allowing us to undertake this project. So this is a collaborative project between UCD, St. Vincent's Hospital, and the Royal Victoria Eye and Ear Hospital. And we're hoping to quantify circulating tumour DNA in uveal melanoma patients. This is a pilot project. I suppose I'll just give you a little bit of background. What is uveal melanoma? So it's the most common intraocular malignancy in adults, and it's the second most common form of melanoma. We see about 70 new patients per year, somewhere between 50 and 100. And over the last 50 years, there has been a revolutionary change in the local tumour control, but we haven't seen a corresponding change in the prognosis of these patients. So for instance, 50% of people with uveal melanoma will develop metastases, and mainly we see them in the liver. And when they develop metastases, despite new treatments, the overall survival is less than 1 year. So this is what we see. This is a phenotypical example. This is the frontal photograph of a patient's right eye, and you can see this raised pigmented lesion in the superior arcade abutting the optic nerve. And this is basically a uveal melanoma. When we see this, we know what it is. With regards to risks of metastases from these lesions, what we used to look at is how big it was, how thick it was, whereabouts in the eye it was. And this could be gained from using multimodal imaging, such as wide field images of the fundus, autofluorescence images, ultrasound images, or OCT scans. However, recently, we looked at the genetic and the molecular markers, and this could offer more accurate prognostication, for instance, BAP1 mutations, or monosomy 3, or 8q loss or gain. So, but to get this information, we had to take biopsies. And if we take a biopsy, we risk a certain side effects. So the overall goal in uveal melanoma is to save the life, save the eye, and save the site. To get these biopsies, we either get them by fine needle aspiration or via enucleation in severe circumstances. But this risks, with fine needle biopsy, we risk on the top left, you can see a retinal detachment. On the top right there is a vitreous hemorrhage and a retinal hemorrhage. And the bottom is the severe sight-threatening complication of an endophthalmitis. So we need to think of a new way of getting these biopsies. And also these biopsies only give us a snapshot of the tumor's current histological state. And this is dynamic and fluid, and this can change over time. So you need to do repeat biopsies, and simply this is not feasible. So we're looking into a new and emerging modality called liquid biopsies, and this can look at the molecular features of the tumor by taking bodily fluid, be it vitreous, aqueous, or more easily a blood sample. So we can look at circulating tumor cells, circulating tumor DNA, cell-free RNA or microvesicles, and this will give us an idea of the genetic and molecular makeup of these tumors. With regards to uveal melanoma, luckily 90% of the mutations are either GNAQ or GNAQ11 in the Irish population. So we can hone in on these, and we can use digital drop PCR to look at this. And ideally, this will give us an earlier prognosis, an earlier diagnosis, an idea of prognosis, and we can repeat this over time and hopefully give us a better molecular understanding and can offer us real-time monitoring as well. So our study, it's novel. It's between UCD Chas, UCD Conway Institute, the Ioneer and Vincent's, and the Ioneer receives nationwide referrals for uveal melanoma, and Vincent's has a well-established systemic surveillance system for these patients as well. So these two hospitals have the largest cohort of patients undergoing surveillance from an ocular and systemic point of view in the country. So what we hope to do is to analyze the blood to detect and quantify this circulating tumor DNA at initial diagnosis and at 6-monthly follow-up intervals. And then we hope to prove in principle that by looking at these markers from both a qualitative and a quantitative aspect, that we'll be able to detect metastases before radiological evidence of the same. So where are we now? We're currently optimizing our PCR for the analysis of these patients for the GNAQ and GNAQ11. We have our ethics submitted and we're waiting for approval, and we're currently recruiting patients. Again, I'd like to thank St. Vincent's, the Academic Health Science System, our collaborators in Vincent's being John Crown, in UCD, Professor Brennan Kennedy, and in the Ioneer, Mr. Noel Horgan. And that was a very quick whistle-stop tour because I'm conscious of time as well. So any questions that you have, I'm happy to answer.
Thank you very much, Patrick. Fantastic work on everybody's part. We did have one more speaker lined up, Professor Aisling Mulligan, and I'm not sure, Stephen, do you know if, let me see, I think Professor Mulligan is here, yeah.
Aisling is listed as a panelist.
How are you doing? Aisling Mulligan coming in here from Copenhagen today.
Oh,
Coffee, my colleague. How are you doing, Tomas?
thanks, Aisling. I'm delighted to introduce Professor Aisling Mulligan, consultant child and adolescent psychiatrist, clinical professor in child and adolescent psychiatry in UCD, and an old classmate of mine. So she works with the HSE in Grange Gorman and with UCD, National Clinical Lead for ADHD in children and adolescents. She has research interests in ADHD, development of mental health assessment tools for children, director of the MSc in Child Art Psychotherapy run by UCD. And from that, she has liaised with child art psychotherapists to develop mental health self-report assessment tool for young children. This led to development of the digital mental health assessment tool called telTaz. Thank you very much, Aisling.
Thank you. I'm going to try and share my screen now as well. Can you see that? So just to talk about the telTaz digital mental health assessment tool that we've been developing. Now, as I'm sure you are aware, there is a difficulty at the moment with children's mental health. So there are a lot of children to be assessed very rapidly. We have developed a digital mental health assessment tool called telTaz for screening children's mental health in a trustworthy and evidence-based way. So our mission is to identify children's mental health symptoms early so that we can get and intervene at the right time with the right help with better outcomes. 1 in 5 children have a mental health difficulty, and many of these children are not treated and they just manage. So what we would like to do is to target the right treatment to the right children. Recently, we've actually had a 33% increase in referrals to CAMHS since COVID has happened. We've also got, at the moment in Ireland, there are about 11,000 children on primary care wait lists. They're children who may not have major mental illnesses, but have some difficulties which need to be addressed. And it's children like that that we would like to help with our telTaz mental health digital tool. It's a tool that's geared at children in the primary school age group. Now, 70% of young people who experience mental health difficulties have not actually had appropriate interventions at the right time or at the right age. So we're hoping that by developing this mental health tool, we'll be able to increase the amount of children that we can work with and address. And that early detection is, of course, the key. Like every illness in medicine, early detection is the key. There's a global shortage of mental health professionals. So some digital tools such as telTaz will, they will help us to access more children. So the current screening tools, a lot of people say to me, well, what's wrong with the current screening tools, or what's different about telTaz digital mental health assessment tool to the current tools? Well, I have a picture there of 3 of the current tools that we sometimes use in CAMHS clinics. And as you can see, they're very paper-based tools. Most of them for primary school children, we actually ask the parents to complete a tool. So it's a black and white form, or sometimes it's a form that's got an awful lot of writing on it. Some of the families that we work with have literacy difficulties. We may have people coming here from other countries, and maybe they didn't plan becoming a refugee, so they're coming with the wrong language or limited English. So filling out these forms are quite difficult for parents and for children. Children lose concentration. The children who need to come to CAMHS are not always the ones who've got good reading skills. There is also a difficulty that the analysis of forms is very time consuming for professionals. So actually, a lot of the time we actually don't even use the forms because, it just slows up your work, and it's not actually quite it's not good for the patient, the doctor-patient relationship and the therapeutic relationship. So our solution, we've developed initially a form that's an improved form. You can see it on the left, the My Feelings form. It's developed with emojis, and it was also developed with healthcare professionals. We did some focus groups to find out what were the most important items to put on the form. So we've got 14 items that probe about mental health or psychological distress in children. We developed which were the most important 14 items with a focus group of mental health professionals, and also working with parents and children. And then we put those 14 items on the form, but used emojis with a Likert scale for children to identify how difficult or how much of a problem they have. So they score their difficulties 1 to 5 using these emojis. And then we also we supported some of our questions with cartoons. So you can see 2 of the cartoons there. I can tell someone how I feel. And another one is, I hurt myself on purpose. So that question, I hurt myself on purpose, is obviously a crucial question in child and adolescent mental health. So it's the inclusion of that question that turns this form from being just something that kids complete it turns it into a mental health assessment tool. Having that question, I hurt myself on purpose, means that we are identifying true psychological distress that's of relevance to mental health professionals. And it gives me the ability sometimes to discharge people quite early if they can say I hurt myself on purpose is actually at 0 level. So this is a form that can be quickly and easily completed by children in the primary school age group. And then our next thing was to change this to a digital tool. So we linked with people from DCU, the School of Computers, and they very happily, nicely put it onto a digital tool. So we have an app or a digital tool that's accessible on a phone or on an iPad or a computer. But the idea is that it's always started by the use of it is stimulated or commenced by a mental health professional, a doctor or a therapist. You can see the paper-based form on the left-hand side there again. 14 questions on anxiety, low mood, daily functioning, and risk to self. And this is our digital solution. And just to say, what is our AHSS grant about? So we had already produced the form and published the form in an international journal. We'd published the use of the form in a general school, full school, and we'd also published and compared it with the use of the form in a CAMHS clinic. So it's at a mental health level, and it's useful to identify children with true psychological distress from the general population. So we've proven that. And then we had also developed the app, but what we need to do is to test the app further in CAMHS clinics. So what we did was we linked in with a number of child psychiatrists nationally in the IEHG group, and we linked in with a number of paediatricians in the IEHG group. And just to list them out, the people we're listed with is especially Dr. Alfonso Rodrigo Herrera in St. Luke's Hospital, paediatrician, and other paediatricians were linked with our Professor Farhana Sharif in Mulligan Hospital, and Dr. Maybelle Wallace in Wexford General Hospital, Dr. Charmaine Van Heerden, paediatrician in Wexford General Hospital. And we're also linked in with child psychiatrist Caroline Noon in Longford, Westmeath, and with Dr. Peter Fitzpatrick and Dr. Peter Braben, both in CAMS in Kilkenny, and Dr. John Fagan in CAMS in Wexford. And all of this project has also been facilitated as well by child art psychotherapist Anne Coffey, who's here with me today, and child art psychotherapist Maria Joyce, who's not here today, but they've been involved in the creation of the telTaz app and the My Feelings form. But what we're actually going to do now is we have our ethics approval to do a usability study using the digital telTaz app in the CAMS group and actually in pediatric groups as well. So we have that ethics approval through UCD Ethics Committee, and we also have the ethics approval with the HSE Dublin North City and County CAMS. So we had both of those ethics approvals prior to applying for the AHSS grant. And we plan simply doing a usability study with about 30 children and families in the pediatric and CAMS clinics and getting feedback from the parents, from the children and from the healthcare professionals about using the app, you know, and what it's like to use, and to observe the child, the parent and the healthcare professional using the digital mental health assessment tool, and to do a brief interview with them following that. Now it's planned that this usability study will be used to upgrade the app before we go on to do full validity studies with the app. So we will progress on after that to full validation studies. But we'd like to get, you know, find out what are the glitches in the app before we progress to full validation studies, so that when we have it validated, we validated the final tool. So I think that's really most of my presentation. Just to show you as well, it's all about stay left, shift left. So it's a tool that will help us to detect early, intervene early, and that should, you know, take the burden off the healthcare service. So the use of the telTaz app in CAMS or in primary care or in school settings should help people pick up difficulties early and intervene early, so that down the line it should reduce the number of children presenting to CAMS with very serious illnesses. It will help children communicate about their difficulties, so that they can get care early, or so that they can even communicate through to people who are in their world already with their teachers or their parents. So just to say, at the moment, telTaz will always be held in the healthcare setting and initiated by a healthcare professional or a teacher. So it's not planned that this will actually go out to the general community. It's planned only for use in healthcare settings. So I think that really concludes my my talk. This is a little bit about our timeline, and I'm open for questions.
Thank you very much, Aisling. That sounds fantastic. We all know kids are so tech savvy, and you know they're on their phones and tablets and things like that. So this would seem to be a very user-friendly app, you know, to allow people to communicate, and you know, it's moving with the times. So fantastic. And there's a bit of a common theme in terms of some of the presentations in terms of early detection of issues, reducing in terms of midwifery, reducing unnecessary potential interventions like epidurals, detecting kidney disease early, so reducing downstream complications, and same with ocular malignancy, and of course increasing healthcare professionals at work. So it's all about improving care for the patient. And just like to say thanks so much to all of you for all the time. And I know it takes a lot of personal time and effort to do these projects, and they're all very admirable projects. So well done to everybody who's, particularly people doing this on top of a clinical job. So so fantastic presentations. Thank you so much. If anybody from the panel has any specific questions, we are over time. There's nothing in the Q&A that I can see, but any comments from any of the panel?
I don't have any questions. I know I hugged the virtual screen earlier, so sorry. I just want to say that was absolutely fantastic. I really enjoyed every one of the presentations, and the research is just phenomenal coming out. And that's all I'm going to say. I'll be quiet.
Thanks, Denise, and I echo that. It's inspirational, really. I mean, everybody here is working in a project which is improving patient care, which is really what we're all about. Why we all, you know, signed up to do what we do. So, well done. There's something in the Q&A. Oh, well done, everyone. So I think that's a common theme. So if nobody, oh, there's a couple more comments, I think. Excellent presentations. Yeah. Okay. Well, if nobody else has any comments, we will leave it at that for this morning. Thanks so much to everybody. Thanks to Stephen and Kazia and to all the presenters. Well done, everybody. And sorry for being rude earlier and cutting in on people, but just trying to keep things running along. So well done. Thank you so much.
Thanks, Thomas.
Thanks, Thomas.
Thanks.
Good to
Thanks
see you
very
all.
much.
Take
Thank you.
care.
Great, thank
Have a
you.
good day. Have a good weekend.
Thank you.
Bye.
Bye.